opening with an adult, okay, so here's the going down, it's straight down. When we have a pediatric patient, we have melodic opening, and then it actually gets narrower. And that's why you don't need cuffed intratracheal tubes for kids. Now they do make them, but the problem is that you can overinflate this, put too much air in that cuff, and you actually cause tracheal stenosis, where that trachea gets really, really hard and rigid, and there's a narrowing to it. And I'm going to tell you a story eventually about that. It's really crazy. So that's why we don't use cuff tubes in the smaller children population, is because of the natural narrowing of their airway distal to what? The glottic opening, which is what? Vocal cords. All right. You can use cuffed endotracheal tubes on these patients. However, you actually need a specialized tool. It's called a manometer, and it measures the pressure inside the endotracheal tube cuff. Okay. This is all critical care stuff. All right, Blake, what you got for me? How much do we squeeze the bag?
Once every 6 seconds.
Well, time-wise, how far do we squeeze the bag?
2 fingers touch.
Until it just rise?
You're talking about the volume?
What'd you just say, Stacy?
Something.
What'd you just say?
When you see the chest rise?
Perfect. You see chest rise, let go. That is the optimal ventilatory. Okay, I'll tell you a quick story about this. So there was a respiratory therapist on the neonatal team. Her name was Lynn, and she was like badass ninja respiratory therapist. I mean, she could ventilate anybody. Sick patients. And when we had those really sick patients that we thought we'd have trouble ventilating, we took one of the neonatal respiratory therapists with us. And so this, sure enough, and I'm like, Lynn's going with us on this trip. Really, really sick patient. Horrible vent settings. And I'm like, shit, I'm fixing to get my learn on. I'm fixing to learn something today. I'm all excited. I get to ride with Lynn. Lynn's gonna teach me all this magic stuff so I can get better at ventilating these patients. So we get there and Lynn does this, walks away. I'm done, I'm ready. I said, Lynn, what'd you do? And she looked at me and she had this really strong southern accent. She goes, Mel, just move the chest, and walks away. And what she's getting at is if you can move the chest and you can see chest rise, that's the goal. It's really simplistic. Move the chest. Okay, and see chest rise, you're getting an adequate tidal volume. What's tidal volume? Amount of air that you breathe in one breath. All right, so here's a formula for you. Write this one down. Five to 6 milliliters per kilogram. 5 to 6 milliliters per kilogram. That's what your normal tidal volume is. So what happens if we have a 400-pound patient that weighs 200 kilos? No. What you do is that you use it for a normal-sized person, an average physiologic person. A patient's lungs who's 400 pounds are the same size as yours. All right?
They're just fat.
They're just fat. Lung size does not increase with body surface size, so it's 5 to 6 per kilo per patient. Okay? So I'll give you a ballpark idea. Most tidal volumes that I've ventilated over thousands of patients, their tidal volumes between 500 and 600. If I'm at 650, it's somebody that really, it's a big person, big man. If I'm over 600, but mostly it's 5 to 600, their tidal volume. Okay, so 5 to 6 per kilo. And remember, it's the normal physiologic size of the patient, not their weight. Everybody understand that? Okay. All right, what else?
What was it? Cornigo tracheal lumen? PTL?
Don't worry about it.
Oh, all right.
Don't worry about it. PTL's waste of time.
We'll go over
Capnography. Capnography. Okay. I don't spend a lot of time on capnography waveforms. And the reason why is that they can get very detailed and very specific. So I like for you to know the shark fin waveform. So if it looks like a shark fin waveform, that's COPD, they're retaining carbon dioxide. That's the one I want you to remember. Shark fin waveform, holding onto carbon dioxide molecules. Got it?
Got it.
COPD. All right? Sure. Okay, what you got for me? Anything? Mr. Reese? David?
Looking.
Stacy? You good so far? Rebecca? Armin?
LMA fast track intubation.
LMA fast track intubation. So there's LMAs out there that you can actually intubate through. Don't worry about it.
Okay.
He's going to have a test next time.
But what are you doing Tuesday and Wednesday next week?
Nothing.
Chilling. You ain't coming to see me.
Shoot. I'm gonna get
Y'all do not want to be with me on Tuesday. I have to sit through a day long of in-services that have nothing to do with what I do for a living. It's a waste of my time.
I say.
I think I'm gonna be sick.
Want to get a shot of tequila with some mango in it, fucking sugar on the front.
Can I do tequila and pineapple?
Fuck it, yeah, man. We can go crazy.
Mason, questions for me. Rawson for me. Questions. All right. How about that I pull out the test? Ooh, I got your attention there. Ooh, except for these two guys. Y'all are excluded. Y'all can leave.
What the hell I do?
You're sitting next to him. You're his accomplice.
Oh my God,
All right.
man.
How about if I go through the test, the questions I have so far, and I make sure I've gone over everything.
Sounds good.
All right, we didn't talk about pulmonary embolus though. Before we do that, let's talk about pulmonary embolus. All right, pulmonary embolus is its own little disease. So this is the typical clinical presentation of pulmonary embolus. You arrive on scene to somebody who has a DVT. A DVT is a deep vein thrombosis. It's usually in their lower extremity. And usually they have decreased pulses and it's just a blood clot in their lower extremities. Usually it happens to obese females who are on birth control and who smoke. Those are the kind of the category of women who are at very, very high risk. But it can happen to anybody. So the way this presents is that deep vein thrombosis for some reason dislodges. So what they usually do is the patient complains of their legs hurting, all of a sudden their leg quits hurting, and now they're having trouble breathing. All right, so let's break this down. So we have a blood clot in our calf. If that blood clot breaks off as it's traveling north, are the vessels getting bigger or smaller?
Smaller.
Bigger. It's going back to the heart. Okay, venous side, they're getting bigger, right?
Vena cava.
Are they getting bigger or smaller?
Bigger.
One more time?
Bigger.
Thank you. So it breaks off. So it migrates, femoral vein, then it goes to the iliac vein, which is in your pelvis, and then it goes to your what? Inferior vena cava. Then that blood clot's going to dump into where? The right atrium, through what valve?
Tricuspid valve.
Tricuspid valve into the right ventricle. Right ventricle through what valve?
Your pneumonic.
Pulmonary semilunar valve into the pulmonary artery. Now, as it goes into the pulmonary artery, are things going to get smaller or bigger?
Smaller.
Smaller. So the blood clot that was down in your leg migrates to the lungs. So it's not necessarily a respiratory problem. This is what is called a ventilation perfusion mismatch. This is a national registry question. You have to know this, okay? So that blood that's carrying the deoxygenated is now a clot and it gets dislodged or lodged in the pulmonary artery. Now what can happen? We can't get blood to where? The lungs. Okay? This is why it's a ventilation perfusion mismatch. The blockage is causing a perfusion problem. We can't get the blood offloaded to oxygenated carbon dioxide, then it turns into a ventilation problem. Their lung sounds are clear, but they can't breathe. Severe respiratory distress. There are 4 things that you're walking along, minding your own business, and boom, you're dead. This is one of them, pulmonary embolisms. All right? Usually happens either after a surgery, immobility, and what were the other things I told you about?
Birth control.
Morbidly obese people, women specifically, birth control and smoking. Those are all high risk factors. But you have somebody who's 270 pounds, who sprained their ankle, and they've been in a cast for, 3-4 weeks, and they have severe pain to their lower extremity. All of a sudden they get their cast off, that clot dislodges, moves north. And remember, as it gets north, it's bigger. But when it leaves the heart, it gets
Smaller.
so it lodges.
Why'd you treat it in the pre?
Non-arrhythmic intubation. There's nothing you can do. They have to go to the operating room. And it's usually a very high mortality rate. All right, so back to my thing. There's 4 things that causes you sudden death. Walking along, minding my own business, boom, I'm dead. I just told you one. What was it? Pulmonary embolism. The second one is a lethal arrhythmia, ventricular fibrillation. The third one is a dissecting or ruptured thoracic aneurysm.
AAA.
Okay? AAA is abdominal.
Oh.
TAA is thoracic. It's separated by the diaphragm. Anything below the diaphragm is a AAA. Anything above the diaphragm is a TAA, thoracic aortic aneurysm. All right?
Wait, so what?
And the last one, stroke, head bleed. Those are the 4 things. You're walking along, minding your own business, and you're dead. There's only one that you can survive from. Which one? Lethal arrhythmia. You can shock it and potentially get them back. The rest of them, 100% mortality. They're dead. All right? Okay. Any questions about pulmonary embolus in the clinical presentation? High flow oxygen, go. It is a national register question. Well, they'll say, what condition is a ventilation perfusion mismatch? Or they'll give you a clinical presentation of, you arrive on scene to an obese female, started having acute onset of difficulty breathing, is a smoker, and is on birth control. You know that's pulmonary embolism all day long. All right. Everybody understand why their lung sounds are clear?
Yep.
It's not a problem with the lungs. It has to do with perfusion of the lungs. All right, any other questions? Let me take a peek at this test to see how many questions I've gotten so far and make sure we've gone over it. Sound like a plan?
Yes, sir.
I need to take a quick break.
We can have that Mexican place, bro.
We're going to the Mexican place.
Yeah, boy.
Key food.
Those are my people!
KK, are you
Get a
going to take
motherfucker
this
say,
afternoon?
arriba, arriba.
Come to Lebanon.
What's your
I
plan?
haven't
That's
seen
not,
that.
I wasn't ready for it. That wasn't.
I
hope.
don't want to miss
I wasn't-
anything.
¿Qué te pasa?
When we leave here, I can go check for you.
¿Qué te
Oh,
pasa?
Estaba
I don't
comiendo
want you to miss it.
Yo.
que lo tienen los pantalones
Shit.
en el culo.
It's better for you
Yo no sé qué
to
tengo en el
go
culo.
home and chill.
¿Qué te gusta? Ah, entonces, porque
And
tú
then,
miras.
worst case scenario, we'll catch up.
Mi como pollo.
Know what's going on.
I mean, I drink a little.
No, I just realized I fucked up.
It's the only thing I learned how to say in
I just realized I fucked up.
Spanish. I eat chicken.
So I went at 8 a.m.
you fucking
My
stupid.
Spanish teacher was not very good.
Am I able to show this like?
Some wipers?
Yes.
Either
Wow,
one.
She was really good at speaking Spanish. She was just a really bad teacher.
So I would send an email to BJ.
Shot it in the middle of the parking lot.
Yeah, so you can get, you know, early leave. That'd be the easiest way to handle
You
it.
probably knew that shit.
I looked at this thing a dozen times, and that's the first time I noticed it. Hey Siri, call shitter.
Wow.
I have a question now.
I have an answer.
I haven't double checked it yet, but I'm pretty sure. I have a respiratory clinical, and I didn't even realize it or like make sense of it until I looked at it again. I think I have to look at it again, but it's on a morning where I'm coming off shift.
You having the same problem Rawson is. When is it?
I think it's 7 a.m.
What day?
Probably Tuesday. Because I won. I'm probably going to put in sick leave. Although I don't feel so good. Sick leave is going to be used on March something. March 3rd or 2nd.
Be careful using your sick leave. Use your annual time. If you can. First
Yeah.
try your annual
Oh.
pre-schedule. Then if
I've
you
been
can't
trying
get
to
it-
wait for someone to call, like, to cancel their vacation, but none of these
No,
fuckers haven't.
don't do that. Unless
Ryan, you gonna survive?
unless there's already 8 people that called out.
Yeah.
That's it.
Yeah.
We'll see.
Then maybe you have to.
You know why you're sick, right?
Why?
You sit next to Trevor.
Yeah. Yeah.
28.
I haven't like really eaten in like almost 3 days, so
Wow.
Yeah,
We're almost done. We're gonna look at this
Eat
test
some
real quick.
chicken
I
noodles.
have no appetite.
it's